Yes, welcome to our today's meeting on the future of healthcare for older adults living in urban areas. My name is Wolfram Herrmann. I'm professor for general practice and health services research at Charité Universitätsmedizin Berlin, which is part of the Berlin University Alliance. And I'm very happy to welcome you today here on site in Naturkunde Museum in Berlin, in the Birds Room, and also online via Zoom or via streaming to our session today. It's going to be 1.5 hours about the future of healthcare for older adults in urban areas. This is a pressing need. In the next 10 to 20 years, this topic will be emerging and be very important for cities in especially developed countries. And especially Berlin and Singapore are going to be cities which will have this need to talk about these topics. And thus we are very happy to have today this joint session between the National University of Singapore and the Berlin University Alliance on the future of healthcare for older adults. We are going to have 4 talks by 4 professors from Berlin and from Singapore on these topics to highlight different aspects of these topics. And afterwards, we'll have time for discussion. And I'm very much looking forward to these discussions after the presentation. So first, you'll have 4 presentations, and then there's enough time left for your questions, your comments, your remarks, and your discussion. We will start with the presentation from the National University of Singapore. There will be 2 professors we are working together in a project with. We are very delighted to work together with. First is Professor Angelique Chan. She's a sociologist and professor at Duke National University of Singapore Medical School, and she's the executive director of the Center for Aging Research and Education. And she will be then accompanied by Professor David Matcha, who is a medical doctor and internist. He's professor both at the National University of Singapore and at the Duke University in the United States, and his work focuses on health services research and policy aspects. And I'm very happy to have these 2 here, virtually of course because of the pandemic. So we are very much looking forward to the talk of Professor Chan and Professor Matcha from Singapore.
From Singapore, we have members online who are also part of the project, Dr. Visaria, Dr. Raki, and Ms. Nawal. And the topic is understanding the health and social needs of older adults in Singapore. So I will start the first half of the presentation to give you context of Singapore and the need to really look at health and social needs of older adults. So if I could have the next slide, please. If you look at this slide, you'll see that the proportion of the population aged 65 and above is increasing very rapidly in Singapore, which is this blue line. Of course, Japan will always be ahead of us. And interestingly, by 2050, South Korea will be ahead of Singapore, but there's a very dramatic increase in population aging, and it's taking off as we speak, almost exponentially. Next slide, please. And one of the other things that I like to mention is the increasing percentage of the population above the age of 80. And the reason I say this is because currently our life expectancy in Singapore is roughly 84.3 years. And we see a lot of onset of disability and dementia in this old age group. And they are indeed the fastest growing segment of the Singapore population at the moment. So I think it's important to think of aging not as one lump, particular group, but that there are different needs at different times in your life when you are older. Now, in Singapore, we have one of the lowest fertility rates in the world. We reached below replacement total fertility rate in 1975. and our current fertility rate is 1.1. So for those of you who are not demographers in the audience, that means the average Singaporean only has one child, average couple. So in light of this, we also have an increase in total life expectancy, dramatic, and it's one of the highest in the world. Unfortunately, this is being accompanied by increasing rates of divorce and non-marriage, increased female education and employment. And I mention this because it involves family dynamics and caregiving and the availability of caregivers. There's also fewer working adults per older persons aged 65 plus. So fewer younger people because of our low fertility to support older people aged 65 plus. That's not to say that older persons in the age group cannot be productive in and of themselves, but it is reality that there are fewer younger people paying taxes. There's also migration out of Singapore. It's not a huge problem, but it is there. And so these changes result in fewer caregivers available to provide care. And the research question is, how can we fulfill the health and social care needs of older persons in Singapore? Next slide, please. Now, one of the things that we know that living longer does not mean living longer in better health. One of the things that we study is health expectancy. So the analysis of both healthy and unhealthy years of life, where health can be defined among various dimensions. And existing research shows that at age 60, individuals are living longer with worse health, especially women. And this is research that's been done in Singapore and Japan. In Singapore, at age 60, a woman will spend 77% of her remaining years without disability, compared to a man, average Singaporean male, will spend 88% of his remaining years without disability. So there are very obvious gender differences in the health and social needs of older Singaporeans. Next slide, please. Now, one of the things that is also happening is that Singaporean cohorts are changing over time. So what we call the pioneer generation is a generation of Singaporeans who had very little education and were not as healthy as incoming cohorts. So in our projections, when we account for education, we find that there are fewer disabled young old than expected. However, next slide, please. Our projections show that because, as I mentioned earlier, the 80 plus is the fastest growing population in Singapore, we expect more disabled oldest old than we had originally projected in our Ministry of Health. So there's a very urgent need for integrated care in Singapore, particularly for the oldest old. Next slide, please. So what we need to do and what we want to do in this project, together with colleagues in Berlin, who also are in a very urban environment, is to understand the health and health-related social needs of older persons. Because we can't design programs without understanding what their needs are. The second thing is to review the adequacy of the current healthcare system to meet these needs. And I think this is very important, to do a review of what's happening now and where are the gaps. And the hope is at the end of the project to have suggestions of ways to adapt the healthcare system, policy and programs to support older persons in order to prevent and manage health and social issues. Next slide. So this is where I will hand off to Professor David Machar, who is going to talk about how can we understand health and health-related social needs in a population, in this case in Singapore and in Berlin. Over to you, David.
Well, thanks, Prof. Chen. So this has been a great opportunity to work with the group in Berlin to deal with an issue which I think is of common interest. And the work that I'm going to describe is something that's been going on between the Center for Aging Research and Education, which is the center that Prof. Chen, Professor Chen directs, and my lab, which is what we call the Health System Design Lab at Duke NUS. And it's specifically what we've been focusing on with my group is the question, how do we assess needs in a relatively efficient way that really captures the nature of the service needs that individuals have, and not just the medical needs. So a lot of efforts around population segmentation have been oriented towards how many people have certain diseases, or who are the people who are most likely to die, or who are the people who are most likely to have very expensive medical bills. But really, it doesn't get at the question of what can we do about it? What are the actionable, what are the things that we can do that we can act on in order to improve the health and well-being of the population? And that includes both what we traditionally think of as medical services, but also the social needs, which are very strongly predictive and influential on health outcomes. So to give you a little bit of background from the medical perspective in Singapore, one of the things that's really important to understand is that Singapore developed its public acute care and advanced care, secondary and tertiary care systems very aggressively, such that secondary and tertiary care is a part of the public system. About 80% of services that are that are secondary and tertiary care and specialty services are in the public sector, whereas in terms of primary care has been left largely historically to the private sector, and the government has historically had relatively little influence over the way in which care is provided, and so there's relatively little communication or integration between the outpatient and the inpatient service sides. And one of the things that has happened as a consequence is that we've experienced a series of problems, which in Singapore we call pain points. And the three pain points that have been identified consistently have been some that already Prof. Chan has already mentioned, which is lack of intermediate and long-term care capacity. There have been issues around hospital bed capacity and the increasing amount of out-of-pocket costs that are incurred, because in the Singapore health system, even in the public system, everyone pays something. It's really part of the philosophy of the health system is that everyone pays something. And so those out-of-pocket costs, even for the public sector, have risen. Just to give you an example of how that pain is manifest, this is a study that one of my PhD students, MD PhD students did, looking at the way in which hospital beds are being used in an acute hospital in Singapore, and assessed how many of the bed days were being used for what would be expected to be acute care needs. Okay, in other words, did they really need to be in an acute care hospital? And from this slide, you see pretty vividly that only about 50% of the days or bed days in the hospital were being used for this older population for acute care needs, that the other needs were things that could be done in other settings, potentially less expensive settings, potentially safer settings where you don't have to worry necessarily about getting hospital-acquired infections and so on, and certainly a less expensive place. That situation is unsustainable. We've done some projections looking at the rates of hospital use, and actually the rates of hospital use per capita for the older population is actually rising. And we believe that it's rising in large part because this older population, as they get more complex, end up being referred into the public sector. And when they get referred into the public sector, they naturally flow into the hospital and tend not to flow out because they don't have a primary care physician who can provide services when they leave. So we started with this idea about population segmentation. It certainly wasn't something that our group invented. This was actually one of the formative efforts was by Joanne Lynn and colleagues in 2007, published a paper looking at population segmentation based on needs and called it the Bridges to Health model. The basic notion is that the success of health and social services, and in fact, the success of the healthcare system, broadly speaking, which includes health and social services, depends on meeting needs. In fact, it's the definition. We meet needs, people do better. And segmentation of the population is based on service needs. The intention of this is to promote three particular functions. One is to be able to document, as Professor Chan mentioned, document the needs that individuals have, both met and unmet. Those are medical and medically related social needs. To be able to identify opportunities for service innovation based on those patterns of need, and particularly patterns of unmet need. And then it also allows us to more efficiently evaluate those service innovations in terms of how successfully they are, how successfully they do meet those needs, and how successfully they meet them in a way that is sustainable from an administrative and economic perspective, and humane, that is to say, is something that is acceptable to the population, to the people who are users of the health system, as well as to the providers of health services, so that they don't burn out. So we developed a tool. This is the first version that we developed, and it's the version that I particularly like. It's one that's used in a clinical setting by physicians and nurses. It's a very brief instrument, and I'll describe what it is collected here, but it's meant to be a very parsimonious, a very simple measure that captures what providers think of when they think of what makes this person more or less complex to take care of, and what sorts of services, what level of services that I need to provide, or I need to have arranged, I need to arrange to have provided for this patient. So it was really very, very much oriented towards trying to be as efficient as possible. And in using this instrument, we've tested this on several thousand patients being evaluated by both physicians and nurses, and showed that this is an instrument that can be filled in reliably between physicians and nurses, and that the results are very predictive of outcomes, costs. So all the things that you'd want to have in a segmentation instrument that I mentioned earlier. But it also allows us to segment the population into health and social service needs. And just parenthetically, we also have a version of this that can be done in a survey setting, and also a version that can be applied to national data like or international data like the SHARE data, which is available in Germany. Now, the concept is that we think of needs as operating in two dimensions, the first being the medical needs segments, and rather than thinking about individuals as falling into specific disease categories or specific conditions. We talked about them in terms of the nature of the services that we would need to provide to them in the traditional health system, ranging from the kinds of things that you want to provide for a healthy population, which relate to prevention, immunization, screening, and so on, all the way to the palliative services for those people who are at or near end of life. Excuse me. And so each one of these categories, when you describe them to a clinician, to a provider, they can generally say, yeah, I have a general feeling of what it would be like to take care of somebody. But there's really more to it than that. In fact, there are other needs or other characteristics that define needs that individuals have that can make them more complicated. So the second dimension in this segmentation approach is to look at these needs that are not the traditional needs provided or addressed by physicians. First being ADL needs, functional deficits. And you'll notice each one of these generally tends to correspond to a service that might be provided in order to alleviate the problems engendered by that need. So functional deficits, having nursing type skilled tasks, and I say nursing type, meaning things like wound care, which could be done by a nurse, but also could potentially be done by a family member.
Recording stopped.
Rehabilitation type services, efforts at organizing care across multiple providers at multiple locations, lack of activation in their own care, which is generally the ability for that individual to manage their own care.
Recording in progress.
Whether they need potentially to have someone provide services for them. So to what extent can they engage in self-care? Do they have disruptive behavioral or psychiatric issues, which can actually make caregiving much more complex, and also medical services much more complex, and is associated with substantially higher healthcare costs. Social support in case of need, hospital admissions, which is not only important because it indicates that this is a person who has had medical problems and has had required medical services, but also because people coming in and out of the hospital tend to lose connection. So it's an opportunity to fall through the cracks, as the expression goes, when they go into the hospital and then come out of the hospital. And that period of transition is a period in which they can have negative or bad outcomes. And then finally, polypharmacy, which is being on lots of medications. Not only does that mean that that person might indeed have lots of problems, but also too many drugs can induce problems. So one of the things that we then did with this was—
Recording stopped.
One of the things we did with this was to develop an algorithm, what we call a normative needs algorithm, which takes the information from this instrument and then maps it to a series of services, and indeed subdivides it into the kinds of services that are available in Singapore and could be done for any other locale where certain kinds of services may be available in different ways. But one of the things that was really interesting about this, using this tool was that when we evaluated, in this case, 1,000 patients who were discharged from the hospital, and we looked at those people who had chronically symptomatic conditions, and we looked to see whether they were having their normative needs met. Okay, so the instrument suggested at baseline when they were hospitalized that when they were discharged, they were going to have certain needs. We then evaluated them at 3 months to see if they had those needs met, and we had a nurse visit them at their homes to see whether they were met. And then we looked to see how they did over that period from discharge through 1 year. And as we see that individuals who are chronically symptomatic with chronic conditions, who had all of their needs met, and this is just one piece of the information, they experienced fewer rehospitalizations, emergency room visits, nursing home placements, and death. And that was true not only for the aggregate outcome, but also for each of the individual outcomes, which to some extent should be gratifying for those of us in the healthcare system who believe that we're trying to do that what we're trying to do actually accomplishes something. The other thing that we've been able to do with this, and I'm not going to be able to have the opportunity to show you all the things we could do with this segmentation tool, but we have been able to use this in the context of simulation modeling, in which we've been able to project future numbers of individuals with different levels of health and social service needs, which is allowing us to identify whether the projected numbers of services that will be available going forward will be adequate to meet those needs. And so on that, I am going to end, and thank you very much.
Yes, so thank you, and applause for our colleagues in Singapore. I'm not sure if it's transmitted, but I hope you can hear the applause. So thank you very much, David and Angelique. So we are now going on a German perspective, and afterwards we want to discuss all together. As you've already might notice from the aspects highlighted by David and Angelique, you might have realized there are many parallelities between Berlin, Germany, and Singapore, and I want to highlight some of these in my next presentation. Yes, perfect. This one does not work. Okay, so I first want to talk about the developments in Germany in healthcare system and demographics, then go on to the challenges for nursing care and general practice, and finally present some possible solutions for these problems in the future of healthcare. Do I have to say next slide, or yeah, so you've already seen these data for Singapore, and you can see here the percentage or the share of persons 65 years and older in Germany, the projection for the next years. And what you can clearly see, there's going to be from 2020 on, so from now on, a steep increase of the share of persons 65 years and older in Germany. And on the next slide, you can see that what is about the share of those 80 years and older. And you can see here it's a bit delayed. So it's not going to start right now, but it's going to start in maybe 5 to 10 years. And then there's going to be a very steep increase of the share of persons 80 years and older. And what we know is that the demand for healthcare and social care and nursing care of those 80 years and older is the highest in the population. So we're going to look forward to a steep increase of healthcare demand in the next 10, 20 years, and we need to be prepared for that. And that's why we are doing this project together, because it's not only we in Germany which have to be prepared, but it's also people or the healthcare system in Singapore, but we can have a look on a broader level. So in global health perspective, it's in many states and cities worldwide where we have to be prepared for this increase of healthcare needs. If we go to the next slide, you can see, looking in Germany, that the share of people living in urban areas has been increasing since the 1950s. So Singapore is a totally urbanized state, but you can see also in Germany, most people live in cities. And if you have a look on the next slide, you can see that this share is mainly in middle-sized cities. So in gray, you can see those up to 300,000 inhabitants. So there is a larger increase, and in purple you can see where Berlin belongs to 1 to 5 million inhabitants. This part is also going to increase in the next years. So it's not only the very large cities, but also the middle cities which will have an increase in the population. Next slide, please. So what does it mean then for nursing care? The next slide, you can see the need for care, the prevalence in Germany by age groups. So you see that the age group of 90 years, the red one, has a very high prevalence of the need for care. It's more than 70% lately in the latest numbers. So you can see here a clear age dependence on the need for care. This is by the care insurance data. And if we have a look on Berlin, that's the next slide, you can see there is not a big difference between Berlin and Germany regarding the need for care in the different age groups. So it's mainly age dependent, and there is not a big difference between Berlin and the rest of Germany. If we look at the next slide, we can see, so where are people who have, now we are looking at those who have a need for care. where do they live? And we see that a bit less than 20% live in nursing homes, which means what you see on the next slide, that more than 80% live at home. And now, who is taking care of those living at home, which is the vast majority? And on the next slide, we see that only a smaller part, about 25% of the whole population, has ambulatory nursing care of this population needing care. So we can see that 2/3 of those living at home do not receive ambulatory nursing care, but are mainly, and that's on the next slide, without professional nursing care at all. So it's mainly relatives here taking care of these. It's either the spouse usually or the children. And we can compare it now on the next slide with Berlin, and you can see, again, here is not a big difference between Berlin and the rest of Germany, so it's more or less the same shares and the same figures. If we now go on, what is different in Berlin, and especially in urban areas, is that the family structure is different from what we are used to somehow to say. So we see in Berlin, about 1/3 of all adults live alone. That's more than half of all households. So more than half of all households in Berlin are single households with just one person living in these. And you can see if we are the increasing age, the share of those who live alone is increasing. So if we look at the age group 85 plus, it's already 2/3 of persons living alone at home. So there is no spouse or no children living with them. And this will also will be further increase in the future. We expect it to increase in the future. If you look now at the families at the moment, there are many children running around here also in this museum here. So if we look at Berlin, all women who have underage children, so children up to the age of 17, 1/4 of them is a lone parent. And it's about 4% of the male of the fathers who are alone parents. And this is much higher than in the rest of Germany. So we see the family structure, this typical, maybe idealistic family structure. We always think of father, mother, and several children. This is just not the case anymore in Berlin. So we have many lone parents, we have many people without children, we have patchwork families, so we have many different family structures. And this is a challenge for this care, which is right now done mainly by relatives. So if we go on the next slide. Do we need more professional nursing care then? So that's a big question. I think everyone from Germany knows, because it has been very much in the media lately, that professional nursing care in Germany, but not in Germany, but in most countries in the world, to be exactly, is a problem. Especially what we see in Germany is a very low job satisfaction for nurses. So that's something more Germany specific. The job satisfaction is very low. Many nurses drop out of their job. However, we have more nurses than in many other countries, especially interestingly male nurses. Like in the US, we have 1 to 2% male nurses. In Germany, we are soon hitting equality here. But the distribution is very suboptimal. So we have, like in Singapore, people are very often in the hospital. So we have many hospital stays and long hospital stays. And this is a big parallel to the Singaporean system, where it's the same. So we have high load in tertiary care, and this binds many nurses. So there are less nurses for the distribution left for ambulatory care. And something additionally, if you look at nursing homes in Berlin, you can see that we have 357 nursing homes caring for older adults. And you can here have a look on the size of these nursing homes. So the majority of those are up to 50 or maybe up to 100 clients. So they are quite small comparatively. And if we look at ambulatory nursing care facilities, you can see that we have 634 of these ambulatory nursing care facilities, and they usually have very few clients. Some have just up to 10 clients, but the majority is a maximum of 50 clients. So first of all, this looks nice because there's some competition. There's to choose from the ambulatory nursing care. However, what does it mean working together? So a GP practice, having all the adults working together, caring for them, which wants to work together with ambulatory care services. This means in Berlin, in this fragmented system, that you have not one ambulatory healthcare service, like for example in Norway you work together with and you can talk about the patients, but you have 7, 8, 9, 10 different ambulatory nursing facilities you should work together with. And this somehow leads to that you don't work together close with any of those because it's just too fragmented and too difficult to know who is now the nurse taking care of our patient. So next slide, please. So what does it mean? We see there will be an increasing demand for care because of the demographic change, but also because of change in the family structure. We see right now in Germany we have a suboptimal allocation of nurses and we have too few nurses and a declining interest in nursing as a job. This would be a whole talk on itself to talk about these topics, but it's important for healthcare of the future. And we see this fragmented system with no cooperation between, or nearly no cooperation between nurses and GPs. So that's about the challenge in nursing care. What's about the challenge in GP care on the next slide? And again. So what is typical for GP practices in Germany? They are usually solely run. That's not, they are privately run and they are very small. So this is like the same as in Singapore, as we just heard. So that's also a very interesting parallel. But in many countries it's different. So in Germany we have very small practices. You can see that we have in Germany's 27,000, more than 27,000 single-hand practices compared to just 8,800 multi-hand practices. And even those multi-hand practices usually have just 2 to 3 GPs. If we have a look at other countries, it's usual that there are 10 GPs or so working together in primary healthcare centers. That's not common in Germany. It's very rarely that specialists and GPs mix in these practices. It's just 700. What's growing are larger entities, so-called MVZ for the Germans in the audience. However, these do not really mean that they are working in one practice site, but often they are split over many different practices. So they are just organizationally and bureaucratically one practice, but really working together, they are split up in smaller units. So you cannot really say they are integrated care units. And another very typical German aspect, and maybe the most typical German aspect in ambulatory care, you can see down here. And in Berlin, it's even more pronounced than in the rest of Germany. We have in Berlin nearly 3,000 GPs, however, in ambulatory care, only talking about ambulatory care. But we have more than 7,000 other specialists. So it's about 1/3 of GPs and 2/3 of other specialists. And this is very special compared to other countries. In most countries, there are even no specialists work in ambulatory care. They work in outpatient clinics at the hospitals, giving outpatient service. But it's very uncommon to have ophthalmologists in their own practice, or a rheumatologist in their own practice, or cardiologists in their own practice. So this is typical Germany. And here in Berlin, it's especially pronounced. So here we have many, many specialists working in their own practices compared to few GPs, and way too few GPs coming new. So in Berlin, we have about 70 young new GPs graduating per year, and we need at least double to refill those we already have. And what we already have is, from this point, we are looking on the future of healthcare. It's not enough, but we cannot fill the amount of GPs we need for the state at the moment, and not at all for the future, what we need in the future. So this is going to be a big problem. We go to the next slide. Another thing is that GPs in Berlin are very suboptimal distributed. So we have too few, but also these few tend to agglomerate in parts where rich people live and less in parts where poor people live. So you can see here, that's the neighborhood Klickstraße. You can see it with a small red region on the left upper side of the map, and there live more than 8,000 inhabitants and more than 1,300 older adults living there. However, in this neighborhood there is no GP at all, and there is no healthcare facility there, only a dentist. And then students of mine went there in this neighborhood and asked people on the street, do you live here? And if they said yes, they asked, where is your GP? And they mapped it here on this map. And so you can see the distribution where the GPs are located of the people living locally there is very far apart. So that's very interesting. We go on the next slide. Another problem we have is the low flow of information. So you've already heard in the presentations from Singapore that it's about complex needs. And what we have in Germany, we have many specialists, but the specialists and the GPs, the flow of information is not very good. You can see here a PhD thesis of a student of mine who asked the GPs how often do they get an answer if they have a referral to a specialist, how often do they get a letter back with information what happened there. And you can see here that from gynecology you nearly get never an answer. The same with dermatology, orthopedics, psychiatry, ENT and ophthalmologists. Only the internal medicine disciplines like cardiology and gastroenterology, they send letters back. But from the others, if you refer a patient to these specialties, you usually never get any letter back. So you have no information what happens there with these specialists. You can go on the next slide. So this is what I want to prepare you is for the fragmentation in the German healthcare system. And here is real data from German healthcare insurance. So this is a 70-year-old woman, and we would say her care is not fragmented. You can see it's 2011 to 2015. Every dot is a consultation with a doctor, and on the y-axis you see the different doctors, and you can see she is very steadily with her internist as primary care physician, and only very few times with other specialists, but very often she is in the pharmacy to get her medication, to receive her medication. But now we can have a look at the next slide. And this is another real-world example. So this is a 69-year-old woman, also over the course of 5 years. And you can see she is in orange with many different GPs. She's also changing them regularly. So in the middle of 2012, so first she is with 2 GPs, then she changes, is with another 2 GPs for the next 3 years, then changes again, is with 1 GP and changes again with another GP. So she's visiting many different GPs, but she's not only visiting many different GPs, but you cannot read it, but you can see every on the y-axis, every line is another physician. So this is with many different physicians, with 5 or more ophthalmologists, with different urologists, nuclear medicine doctors, etc., etc. And you can see all these, the lines are referrals. So there are very often referrals. However, it's very clear this is extremely fragmented. No one, I don't think even herself, can say what happened there. So if, for example, she is coming into my practice in the middle of 2014 as a new patient, and I ask her, oh, what has been happening to you in the healthcare system in the last 1, 2, 3 years? I think she cannot tell and no one can tell. And even if you're looking about, for the German audience, about the electronic patient records, this wouldn't help here because the electronic patient records would be extremely large and you need at least some technical digital possibility to search it to find somehow the information you need. Okay, so I think this picture shows the problem. Again, we see here the numbers. For example, patients with heart failure in Germany over 5 years, visit 15 different doctors and also 3 different GPs over the 5 years. And they see 148 times a doctor. That means 30 doctor visits a year, so more than every second week. People with heart failure visit a doctor in the ambulatory care system in Germany. And 17 times a year a GP, so every 3rd week they see their GP. So they are very often there. And this leads to the typical German thing that the consultations itself are very, very short. So like 4 or 5 minutes, for example, with an orthopedic surgeon in his or her practice. So this is then together linked with this fragmentation. So go to the next slide. And a last thing I want to add, and you already have seen it in the presentation by David, there are social co-problems, which right now in our healthcare system we ignore. There are studies showing that GPs have very frequent social co-problems, like problems at work, financial problems, problems in their family, in their social life. Loneliness is a very typical social problem for all the adults. We know also in Berlin is quite frequent. However, there is also in Berlin there are many offers and counseling offers, but they are totally separate from the medical healthcare system, and people do not know from each other. So to somehow summarize here, we see there's a core problem in the German healthcare system, which in my opinion, but by I think by these studies you can see it quite clearly, that we demand a high load of organization from the patient. So the patient has to give the information as there's no information flowing. The patient has to keep track of all this fragmented healthcare and has to find his or her way to all these services. This works quite well for highly educated persons. These are fit, privileged, younger people, people who studied, etc., who have a PhD. They usually can do this. However, those who are vulnerable, who have problems in writing, in reading, who have maybe language difficulties, who have a very low socioeconomic status. So those who would need our help and the help of the healthcare system most, they struggle with this because they are not able to do it. They are not able to find the appointments and to transport the information. And this is a main problem, major problem in our German healthcare system. So if we go next, I want to sum up the challenges, but I think I've said everything here already. Hospital care and specialist care dominates. There's a lack of inflow of information and coordination. We have overutilization, especially in the tertiary sector, the same as in Singapore, and no cooperation and no community orientation. So now next we see what might be possible solutions. The next slide. So I want to just very roughly present you 2 to 3 aspects for discussion and also later on. Social prescribing on the next slide is the first option, which is from the UK. So I highlighted there are patients with psychosocial problems, and in the next slide we see they are coming to the GP. And we know from studies that people with low socioeconomic status are very often coming to the GP. So next slide. And again, the next one already. And the idea of the social prescribing is that now we can fill such a social prescribing. Usually they come to us and we can say, oh, maybe you can have a look for counseling, or we send them home, or we send them to the hospital. Now we will have the possibility to have a social prescription, and the link worker is then going to place them with the local providers of psychosocial help, which are already there. So they are there, we don't have to create them, but they are there. And then the patient gets help with this. So that's a very nice model built up in the UK. And what we did is we did a systematic review. On the next slide, you can see the flow here on the effectiveness and efficacy of these interventions. And I just want to highlight a few aspects of this. On the next slide, you can see it's very small, so you just have to believe what I'm going to say, but it's going to be published hopefully very soon as well. So we can see predominantly positive effects on mental health here. Also, we have to say, if you look at the 2 very broad confidence intervals here, you see that the randomized control trials did not really show very positive effects. So it's more lower evidence studies, so that's a bit of a problem. And you can also see on mental well-being, that's the second part, positive effects of these social prescribing interventions. On the next slide, we look on loneliness, which is very important for older adults, and quality of life. And you can see also on loneliness, there have been positive effects. This very broad one with no effect was just with 13 people, so we wouldn't expect here to show any effect by the number of participants anyway. And also quality of life, you can see a positive tendency. Also, not all studies showed a significant effect. And the next slide, you can see the third question, which is also from a health services perspective important. Does it save money? Is it cost effective? And here you can see that in the upper part, primary care utilization goes lower. So people have then to go less often to the GP. But more important, on the downside or on the lower part, you can see emergency department visits. And this is very important. So with social prescribing, emergency department visits drop less, a bit less, but they are less. And that's something which can save much money. And so it's very positive. So we see here social prescribing might be an option. And if you go on the next slide, and another one, the advantage of social prescribing is that we can just use the system as it is. So we only need a link worker and a social prescription. However, you might think further and say that's not enough. We need to strengthen primary care because we need, as we have in other countries, integrated community-oriented care centers with more doctors working in them interprofessionally with others, not only general practitioners, but we need nurses working there together. We need social workers working there together, maybe physiotherapists, ergotherapists, occupational therapists, and others working closely together with a strict community orientation. So we work in a neighborhood, for example, in Berlin, and have a community we are responsible for, and for those older adults and all adults, but especially older adults living in these areas. And then we can work together with the local stakeholders. This will need systemic changes, and that's the last thing I want to highlight for today for just this short impression I want to give. If we want to implement such more innovative organizational care organizations, then we need to change our hospital care. Hospitals in the future need to be focused more on intense high-tech care, what they are able to do best. So this means we need less hospitals and less hospital stays, because only people who need intense care will in the future go to hospitals, and not just for dehydration, for example. We will need that the specialist care focuses on what they can do best. What they can do best is care for severe and complex cases, consulting also GPs and then working together with the GPs. This also means that we need more GPs, because then they have to do more. So we need more GPs. We have to attract the young medical students to be GPs. And these GPs need then longer and less frequent consultations with the patients. So GP-patient consultations have to be less, but then longer. So if we have half an hour with a patient, I don't have to see this patient every second week. So we need to change our healthcare system, and how could we do this? And now that's why working together with Singapore is so important. We have to do this needs-based, and that's where in Singapore developed SST, as David presented, it comes in play. So to have these needs to assess, we need this segmentation scheme the colleagues developed, and at the moment we are applying this segmentation scheme for survey data. We have in Berlin at the moment. We are in plausibility tests, and we hope that soon we will have also results to show how are the needs distributed in Berlin, and how are they locally different. So are there in different neighborhoods in Berlin the needs different? So we can then later on account for that in planning healthcare locally. So this is what I wanted to present you today. And now I want to hand over to Paul Gellert, who's going to highlight a different aspect of health and healthcare of the elderly, which is mobility.
Yeah, hello everybody. Where are my slides? So I'm going to talk about mobility in old age, but I'm just waiting for my slides. So it's about mobility in old age for accessing healthcare and for social participation in urban, but also in rural areas. So my name is Paul Gellert. I'm a professor of social and behavioral gerontology at Charité, and a trained health psychologist. Next slide, please. So, but what is mobility? At least in our presentation, in our research, mobility next slide, please. Mobility is the movement to plan and execute activities inside the person's acting area on their own while adjusting to environmental factors. Next. But when we talk about mobility, then we also have to distinguish certain type of concepts. So the broadest concept is the life space mobility, which basically is the spatial extent of a person's acting area. Then there's a more narrow concept, which is physical activity, which can be mild, moderate, or vigorous, and can be home activities, work activities, travel activities, or sports. And then there's walking, which also can be slow or brisk, and which is very important in your daily routine, especially when you investigate. Thank you. When you investigate older adults' mobility. And then there are a lot of prerequisites for mobility. There's several organ systems that have to work together to be physically active. So we need the brain for movement initiation and coordination. We need the nerves, the muscles, several receptors, and we also need the cardiovascular system and the respiratory systems for energy supply. And when you think about diseases, then of course it's clear that if a disease affects one or several of these organ systems, then it may also affect your mobility. Other way around, if you live an active life, then of course this will be preventive for many of these diseases. And why else is mobility so important? Here we see data from our own study. We asked people over 60 years of age about their mobility biography, and what we have found is that there are people who are constantly inactive across the life course. There are people who decrease their activity over the lifespan. There are people who increase the activity, and there are some people who are constantly active. And what we found is that these activity levels, especially the increased activity and the constantly active people, this was related to well-being, to aging satisfaction, to positive mood, and to better mental and physical health. And as other research has shown, that there are some intermediating factors, which means that access to healthcare and social participation are between these two concepts. But how we do assess life space mobility? So there's a concept of Baker and colleagues, and she uses the life space approach and distinguish several levels of life space. So that's the room or the house, the garden or the neighborhood, the community or the city, or even beyond. And there are two types of different measures that we have been using. So there's something broken. Yeah, so that's the life space assessment. It's basically a questionnaire where we ask people to indicate their life space on a questionnaire basis. So the former version was from Baker, 2003, the English version, but then our group translated this one and validated this one into a German version. And then there's, of course, the global positioning system. So every time you take your mobile and it's talking with the satellite and receiving your position, and of course you could use this information for your life space mobility. And there are two studies that I want to present data from, and the first one is the PsyCare study. It was located in Berlin. We finished this study recently. And we collected data from 197 community dwelling older adults with care needs, so they had all a Pflegegrad in Germany and a clinical depression. So it's a very vulnerable and fragile population. And we asked them about with the questionnaire, we asked them about their life space. And of course, this life space was very, very much restricted. Some people not even left their room. And we found that depressive symptoms and functional limitation were the most predictive indicators for restricted life space in this population. So the depressive symptoms related to drive, to motivation, to mood, of course, limit the life space, and the functional limitations are related to physical decline and physical limitations. Of course, there's a physical component when we talk about life space mobility. But then there's also living alone, and Wolfram mentioned already that loneliness is an important factor in old age. So loneliness was also here very much related to life space. But then on the other side, life space was also related to primary care use and also to psychiatrist use. So if there was the life space was lower, then also the primary care access and the psychiatrist access was lower. In this, people with clinical depression, we have to say, and with care needs. And what we also found that there was no relation to psychotherapy use, but we know also that the rates of psychotherapy use are very, very low in this population with urgent needs. And there's a second study I want to present data on, and as you can see, it's not taking part in Berlin, but near Berlin in the Havelland. It's a very nice region in Brandenburg near Berlin, and there are about 160,000 inhabitants in this very, very large area, and the western part is predominantly agriculture, middle class, and populated by an aged population, and compared to this, the eastern part near Berlin is urban, suburban, and there are also small towns. And the most famous thing in Havelland is the poem of the nobleman of Herr von Ribbeck and his pear tree. So the story is that the Herr von Ribbeck gave pears to children, and when he died, a pear tree grew on his grave. And there's also, as we also heard in the other talks, there's accelerated population aging because of rural depopulation, low birth rates, and also low migration. And the healthcare has to take part across long distances, especially in the rural part of this area. And there's also a shortage of GPs and nursing projected in the future. And here we see a map of the Havelland. On the right-hand side, that's near Berlin. On the left-hand side, it's more the rural part. And the green areas are those with a low density of people living there. And what you see here is the difference in the coming years. And what we see is that the blue areas means that even people move away or die away in this area, so that the density becomes even less, while there's an increase in the suburban and small town areas near Berlin. And if we correlate this with the structure of the aging, the age structure of the population, then we see that, of course, in the rural areas, there are also more older individuals. For instance, here in one of the rural areas, there are 32% of the population are aged 35 and older. Well, this is only 14% when we look into the areas near Berlin. So actually, these are old slides, so therefore I just skipped this. I don't know why this happens. Then I would talk about the mobile project. What we did there is we looked into mobility in old age by integrating healthcare and personal network resources in older adults living in rural areas, but also in these areas near Berlin, and compare them. So the goals were to describe and to improve the mobility by fostering personal, social, and environmental resources. And we focused on people 75 plus, and they were from this suburban areas, but also from the rural areas. And we included people with and without frailty syndrome. This is a syndrome which is related with mobility restrictions. And we ran a cluster randomized controlled trial, RCT, so it's an ongoing trial. It basically means that we plan to include 254 participants. At the moment, we have a bit more than 100 participants included, and survey them on different types of resources. And also we trace them with GPS. And half of these participants will randomly receive an intervention, which is a preventive home visit by physiotherapists. And so here we see one participant walking next to a lake. So sorry, it's old. I have old slides, so therefore I don't know the order really. And here we see parts of the intervention. So the intervention is a preventive home visit, which means a physiotherapist is coming to the people's home, and they have a conversation about different types of resources. There's one type of resources are personal resources, so they set mobility goals. Then there's a type of resources which we call social resources. There the people create a network map where all people who are important for the mobility of the individual, professional resources, but also friends and neighbors and family members were included, and then we find gaps in this network and find potentially also solutions. And then there's also a regional resource map where all the important healthcare professionals can be allocated to the personal and the social resources. This is how it looks like. So the therapist is coming, has a tablet on board. So that's an app that we programmed in this project. And then we have a face-to-face counseling session, talk about the personal goal setting, the network map, and also the regional resources. And then the people will be traced for 7 days. Then we have a break for 1 month, and then we trace them again for 7 days. And then there are many of these follow-ups over a period of 1 year. And here we see some pictures from the GPS tracking from the baseline and from the pilot part of the study. So here we make a visit to our colleagues from Technical University who's familiar with this map. They also programmed all the technical features of our study. And then here make a trip to the Havelland from Berlin. Again, the picture of the lake. And here, my last slide, so this is a trip to the village of Ribbeck, where the Ribbeck Castle is placed, and also where the grave of the nobleman Ribbeck is, and where all the beautiful pear trees are. Okay, thank you for your attention.
Yeah, maybe you stay.
Okay.
All right. Thank you very much, Paul. And I hope now we have time for 25 minutes for discussion, questions, and I hope we can see now the colleagues from Singapore on the screen. So you have possibilities. You can put your question into the Zoom chat. You can post them by hand in Zoom, hopefully, or you can have a question here in the audience on site. But maybe we should wait. Can we have the Zoom to see the colleagues? That would be great.
Wolfram, we've had some nice questions on the Zoom chat already. I don't know if you can see the Zoom chat, but there have been some questions that have come in.
I think, Philip, do you have them? So, maybe you can, I cannot see them unfortunately, but maybe you can read one out and then we can talk about it. Angelique?
Okay. Okay. The first. Well,
Recording in progress.
Okay.
Recording stopped.
Das ist unglaublich.
So as you can see, it's our first hybrid session like this part, so it's a bit technically we have to train these things, so that's also very interesting. So I'm sorry for this delay, but I hope we can still soon go on with the discussion. Maybe in the meanwhile,
I have the questions in front of me. If you'd like me to ask the questions, and then whoever can answer them can answer them. So the first question was about asking about Singapore, about gender differences and disabilities, and I guess the question really looks like it's about whether where do the gender differences and disability come from? And then you did actually have an answer on the line which said that you thought it might be genetic, and also men engage in more dangerous behaviors. And I guess I would add to that answer that women also are more susceptible to orthopedic issues, to joint and bone problems. So musculoskeletal problems are more common in women and can be very restricted. So I don't know, do you have any other answers to that, the gender difference question, Ames?
No, I don't. I mean, this is a question that has been, I mean, everyone is trying to understand why this difference exists. And I think the Max Planck Institute has been doing a lot of work on this. But here, yeah, we just don't really have an explanation at the moment, other than men engage in riskier behaviors over their lifetime. They live shorter, so they have fewer years to have disability.
Then there was a question, I think, that related to the segmentation, which was the nursing type skill task. And I think I sort of tried to answer it on the chat, but basically, we have been looking at whether meeting specific types of needs. So there's a list of 12 potential needs, and we're trying to identify which of those needs seem to be more important to meet. And the ones that seem to be perking up as the most important is supervisory services. That is, supervisory care seems to that those people who are deemed to be candidates for supervisory care do significantly better if they receive those kinds of services. Nursing type services were more complicated. They certainly are predictive of people who do worse, because those people who require wound care, urinary catheter care, nasogastric tube care, and so on, generally are sicker people, irrespective of what their global impression category is. And there do seem to be some types of nursing services that were more likely to be associated with better outcomes, but we're still looking at that.
And I think if I want to add, can I add about these complicating factors? I think they are also practically, like from a GP perspective, they are very important, because having these complicating factors makes the primary care just much more difficult, because you not only have the disease in the global impression, but you also have these extra complicating factors, and that's what's time consuming, and especially for coordinating these different services, which makes them very difficult.
The next question, David, do you want to read it out?
Okay, so what are approaches to substitute informal care provided by family members?
No, the one before that. Could you elaborate on?
Elaborate on expected benefits from backflow from specialists to GPs. In Germany, you cannot circumvent the GP visit because you have to first go to a GP before you go to a specialist. That's a great question, and certainly relevant in Singapore. There is certainly a lot of effort in Singapore to, the question is asked about Germany, so I'm going to refer back to Herman about that. And I can tell you about Singapore.
Well, maybe first the Singapore perspective, that's fine.
Okay, well, the Singapore perspective basically is that it seems to make both the GPs and the specialists unhappy because they haven't figured out they're in the process of figuring out how to do it in a way that makes financial sense. So it's not so much and also that it makes sense in terms of workload. So if you take patients who are being seen by a specialist and refer them back to a GP, in Singapore, the GPs are often very overloaded, and they're seeing maybe one patient every 5 minutes. And so if you take a modestly complicated patient and give them to a GP, then you just overwhelm them. So you end up with an unhappy GP, but you also may end up with an unhappy specialist who may have key performance indicators because they're in the public sector, which is they have to see a certain volume of patients. And so if they take their simpler patients and give them to the GPs, then all the patients that they're seeing are the complicated patients. So it makes their lives more complicated. So it's an interesting dynamic, and I think the way to solve it will have to be making sure that there's a balance in the numbers of providers, and that whatever financial losses might accrue as a result of this flow are taken into account through the funding system.
Yeah, I think I'm not sure if I got acoustically the whole question, but I think it was about the working together of GPs and specialists. And so why is the distribution in Germany so difficult? Because, well, there are different aspects. It's, of course, financially. So a big part of the money flows into a specialist system where it might be more cost effective in the primary care system, because we know usually from also the studies from Barbara Starfield that money spent in the primary care system has larger effects on the health of these persons, and specialist care is just also more expensive than primary care. And of course, it also another problem is that in healthcare system in Germany as it is, the specialists do many things, but you know, I think for them it would be also more rewarding to focus on the complex patients who really need their help. But at the moment, for example, if you look at orthopedic surgeons or orthopedic doctors in the ambulatory care system, they have in Berlin to pay nearly €1 million to buy such a practice, and then they have somehow to get this money back. And what they do is they see patients, about 4 minutes, maybe each patient. And it's very clear, in 4 minutes, you cannot focus on any real orthopedic problems and give any real advice. But it's just, you know, coming in, getting the numbers, getting the ICD code, and getting maybe some medication or some injection or so, and then going to the next patient. And that's not what really anyone benefits from, you know, especially, for example, then you just mentioned with the medication, then the patient has another medication, but the primary care physician never hears about it if not the patient tells them. And then there are, for example, interactions, of course. So that all the typical pain medications have interactions with, for example, all the heart medications we have in general practice. But we do not know about it because we never hear that the patient gets ibuprofen, and then we should tell the patient, oh, yeah, but you cannot take ibuprofen in the 8 hours before you take your aspirin, and etc. So there are many small and bigger problems with this. That's why I think it would be for both sides very well if the specialists focused on their real specialist care. I think they're also not very happy about these 4-minute consultations, and the longitudinal basic but also complex care would stay in the GP practice. However, this would mean, of course, on the healthcare level, that we in the future, that the number of specialists have to go down and the number of GPs has to increase. And that's, of course, something the specialists do not want, in the actual, of course, understandable in the system. Is there maybe a question here in the audience? Now we had from the chat. Anyone a question here in the audience? Yeah? We have a microphone.
Hello. Do you think that the free choices of the patients, so if I want to go to a specialist, I go to a specialist, and if this and if that's not enough, I go to the next one, and then I go back to my GP, and if this isn't enough, I go to the next. Do you think that it should be limited how many specialists and GPs I can visit as a patient, so that the fragmented patient history isn't so much? You know what I mean?
Yeah. There are different. I'm not sure. Maybe afterwards, the colleagues from Singapore can add how it's regulated in Singapore. So in Germany, there's no regulation. You can go to any doctor, and the regulation is somehow done by the doctors. How many patients they accept and the waiting times. In most countries in the world, it's like you first have to go to a GP and need a referral by the GP to go to the doctor. This has some advantages. For example, so a typical, also practical case I saw myself working orthopedic care is that someone comes to our orthopedic clinic, ambulatory clinic, and tells, yeah, he has a back pain for now 3 weeks, like a wheel around his breast and pressing, and it's so hurtful, and especially when he's walking. And then as back from a GP, the red flag is coming up, and I said, you go now directly to the GP on the other side of the street. And then he went there, and later on he came back some days later on and said, oh, thank you, it was a myocardial infarction which happened some time before. But he thought himself, it's back pain, I have to go to the orthopedic surgeon, and that's what he did. And that's not very, in this case, it was not that harmful because it was okay. You know, you could still do the intervention, but maybe it would have been better earlier on. So it's not always the patient who is best to decide where to go because there might be wrong ideas. So I think that's why such a referral system might be very helpful. The question if you should regulate the number of physicians, that's very interesting. I'm only aware that in Norway, there you have a list system. You have to what's common is a list system that you have to register with a GP, and then you're in the list of this GP. And there you can change twice a year. I think that's So if you wanted, so that's the maximum you can do. You can change the list, and you can change, as far as I know, a maximum of 2 times a year. So that's how, then there is some regulation, and they also have this referral scheme, so you need a referral to go to a specialist. So those two things, being enlisted with the GPs and mandatory referrals, they keep the numbers lower and might be very helpful. But they, at the moment, I think in the public in Germany, they are not really, it's very difficult to convince the public that this is necessary. I'm not sure, how do you do in Singapore? Are there any limitations? Do you need a referral to go to a specialist?
Yeah, so that in order to get a subsidized fee for a public, so most of the specialist services are in the private sector, I mean in the public sector. So if you want to go to a GP, I mean if you want to go to a specialist, you need to get a referral. You can go to the private sector, and it just is expensive and you pay out of pocket. So that is has its own set of issues. And there is a small insurance system. So you all have much more insurance coverage than we do in Singapore, private insurance. So what happens is then that the GP, the patient ends up going to the GP just to get the referral. So it's literally just a referral visit. It's almost, I mean, it becomes very difficult for somebody who's only going to have 5 minutes to see you to be able to make much of an assessment about whether your particular problem does, your chest pain should or shouldn't be seen by a cardiologist, because, basically the generalists are very risk averse, understandably, especially when they're very time constrained. So I think, the idea of having a system where your site of first care is going to be a generalist makes a lot of sense. But the generalist has to have the capacity, both in terms of time and training. And one of the other things that's happening in Singapore that is likely to shift is definitely shifting, is the level of training expected for primary care physicians is increasing. So you can't just come out of medical school and be a general practitioner. You will eventually, in order to get any kind of be able to become contracted for any sorts of services, will need to have some higher level of training. And they now have a family medicine register, which is, I think, what will ultimately be how that's dealt with.
Yeah, I think about the referral. It's always very interesting for me astonishing to see the parallels, because here it's the same. We had before some sort of referral scheme in Germany as well, and then it was, and so that's the downside, more or less the same, that people just go to the entrance and work with the secretary there, and then they already get the referral, because the GPs do not have the capacity to talk with the patients if it's really necessary. So I think that's a very important point you highlight here, that if we implement something like this, we also need a higher capacity and possibility for this first point of contact to also deal with these medical problems. And at the moment, we do not really have this capacity, neither in Singapore nor in Berlin. And that's also part of the problem, of course. Are there any further questions in the chat or here in the audience? Yeah, there's another question in the audience.
What do you think, for instance, about the project of World Health Organization and the label for communities or citizens for old age communities? There are rules to attain in citizens or communities the old-aged persons. And this includes meetings, infrastructure, etc., to reach a well-being of the old persons. What do you think about it? Thank you.
Yeah, I think that there are, by the WHO approach, like the Healthy City projects, but also about old age in cities. And I think they are very important approaches from a bit different perspectives, so not from the healthcare perspectives, but from the community perspective. And I know also in Berlin, some of the, so in Berlin this is decentralized, so the Bezirke are responsible for these aspects. And many of these try to, for example, Lichtenberg try to implement interventions to sorry, there's just someone coming in with some noise out. So trying to implement such measures. And I think that's very important. What we need more is to have this bound together. So at the moment, at least in Germany, it's very separate. So we have this community health perspective, the Bezirke with QPK working there, and the health authorities working there, and we have the local health services, but they have no interaction, they have no connection, and no flow of information. And I think that's something where we have here tried to close this gap, and what we are trying to establish also, like in our projects here, also in this BUA context, to work together with the local administrative bodies, because I think it's important that we start talking together and start to try to close these gaps. I think it's very important to look on the community level, because that's where health, the main part of health, is made, also in a preventive way. So it's better to work there than downstream in the healthcare system, but it should be somehow connected, and I think that's going to be one of the big challenges also for the future, because in Germany this is very separate. So there is no interaction between community health and the healthcare system. I'm not sure, how's it in Singapore? How would you describe the cooperation between community health and the healthcare system and primary care?
Jen, do you want to answer that in terms of, I mean, I can give you a little bit of an insight in terms of, I mean, there is some effort in the public sector to develop, there is something called the Agency for Integrated Care, which is making an effort to create a vehicle for making more standard referrals to community-based services. But I think that its reach is still fairly limited. I don't think that it really constitutes kind of a very enriched environment in which primary care physicians can make referrals for social service care very easily. I think that that's still something that needs to be developed.
Yeah, I agree with that, David. I think a lot of the community care services at the moment in Singapore, I mean, we're a small country, have traditionally been done by NGOs. And there are pilots now being undertaken in Singapore to embed nurses and nurse practitioners within communities during the week to help patients who have been discharged up to 6 months after discharge to manage their conditions, and to help patients with medication management, pain management, and any other issues they may have with ADL and IADL activities. But we have not got it perfected. There are still many issues that we need to tweak, but Singapore is definitely trying to build up community health services in the next 5 years.
Yeah, thank you very much. I think that gives a good comparison, and I think that's maybe, as we are coming to the end of this session, I think that's maybe the take-home message for you, or the very interesting thing is, at least for me, and still astonishing, as I already said, that we are struggling with very similar problems. Also, the healthcare systems are quite differently organized and financed between Singapore and Germany and Berlin. But the problems and the challenges for the future are very similar. And I think that's why we are trying or do work together in this Berlin University Alliance project to look for the needs of the older adults in Berlin and in Singapore and compare it, but also look for the methodological difficulties in in applying something from Singapore to Germany. And of course, we then want to do this as a groundwork to work later on together in looking for interventions. Can we do interventions maybe parallel in Berlin and in Singapore to improve and to prepare for healthcare for the elderly? And I think that's why I'm very thankful that David and Angelique took their time in there. Now it's Friday evening already in Singapore to present their idea and their research and to discuss with us, and also Paul Gellert from the Institute of Medical Sociology. So thank you very much for coming and presenting and discussing with us. Maybe we can give an applause for you to Singapore. I hope you can hear it over there. And I also want to thank you all for coming here and for the technical crew for organizing it, our first hybrid event. I think it worked quite well. Also, there were some minor things, but that's always happening. So thank you very much for this work. Thank you for coming. And I hope to see you soon in the one or the other event. And we are going to have also workshops, joint workshops with Singapore. You're cordially invited to take part in them in the spring, in the beginning of next year. So thank you all very much and have a nice day or nice evening.
Thank you.